Well, it's still morning, so I can wish you a good morning. My name is Lisa Boson, and it's truly my pleasure to be here today and facilitate this learning session on a very important topic, and that's of cancer, but particularly cancer related to women's health. Cancer touched my life in 2008, actually the same year that it touched Runzie's life. My mother passed away from a different type of cancer. It was stage 4 pancreatic cancer. But nonetheless, it was just very, very difficult. And if you know anything about cancer, stage 4 cancer is one of the last stages with the poorest prognosis. And generally, the cancer spread and it's metastasized to other areas and organs of the body. And the patient and family members are left with sometimes very little time to share life and create memories. And as much as our physicians give patients a lot of hope, and the caregivers in our areas, the end result can sometimes be very tragic. And so Runzie and I have something in common in that, we've lost our mothers at very end stages of cancer, and we want to try to build on that so that doesn't happen. So cancer touched my life, and cancer touched Runzie's life. And I'd like to hear about how cancer has touched your life. So when we think about cancer, and we think about the illness that affects each and every one of us, I really know we don't want to go down the path of having to have someone pass from cancer. We want life and viability. But specifically today, we're here for ovarian cancer. And through the research and the work that you will hear from today, that early detection and treatment are possible for what I think of, and Runzie thinks, is our world of women out there, the world of women affected potentially by ovarian cancer. So we have a very special connection. We've lost both of our mothers 2 years ago. We were both at their sides when they whispered their last breath. But the really cool thing is we have husbands who work at AIG and are very supportive, and they were talking at work and saying, okay, our wives have something in common, and how can we get them together and help each other on their different projects. So I'd love to share and introduce to you Runzie Sen, the president and founder of Ovarcome, so that you can hear about Ovarcome's vision of possibility.
It'll be difficult to top that one. Good morning, everyone. Thank you for coming and being with us today. I sincerely appreciate you coming out and supporting us at this event. In the next few minutes, I'm just going to give you a brief overview of Ovarcome, our organization, and then hand it over to Dr. Schmeller to start off the presentation. So as Lisa mentioned, I lost my mother to ovarian cancer in 2008, an experience and a journey that completely transformed my life. It's difficult not to be emotional about this, but with her inspiration, I started Ovarcome. And at Ovarcome, we dream of a world that is cancer-free. And our vision is to be a leading global organization where we are helping women overcome ovarian cancer and celebrate their lives. So who we are. Our mission is twofold. We want to raise awareness on ovarian cancer among women worldwide and provide treatment support and options and facilities to underprivileged women in developing nations. We are an international organization that we are really trying very hard to fade our boundaries and unite our hearts in our mission to help women worldwide. And today I'm joined by a distinguished board and a board of advisors who are physicians from MD Anderson and other institutions, and also industry experts locally and globally. So what we do locally, we try to put a smile on people's faces. Case in point, Marisa. She's here with us today. Marisa, can you raise your hand? She's here with us today, and what we did for her on Mother's Day was We gave her a makeover, and as you can see, she looks beautiful with her long hair. And it was a simple gift from us, and it made her happy, her mother Francesca very happy, and most of all us happy that we were able to touch her life in a very gentle way and give her a gift of happiness. We also do fundraisers and educational outreach events such as this one, where we bring together survivors, caregivers, physicians, and support groups to talk about latest diagnosis, treatment options, lifestyle changes, and anything we can do to make our journey with cancer smooth. We have several partner programs in place, and we are working with them to share ideas, provide services, and educate our communities and support women whose lives have been affected by ovarian cancer. In fact, we are working with Ovarian Cancer National Alliance to bring the Southern Regional Conference here in Houston in February 2013 as a host member, and we are tremendously excited with this opportunity. What we do globally. Our global destination, first global destination is India, and we have partnered with a hospital, a very well-renowned hospital called Tata Medical Center, and we are, with their help and engagement, we are identifying underprivileged women who have been affected by ovarian cancer and providing treatment services and options to them. As a phase 2 of our expansion plan, we plan to focus on other developing regions of the world, namely Africa and parts of Asia, South Asia, where thousands of women are affected by ovarian cancer and would benefit from our help. I wanted to share this slide with you just to give you a perspective of how it is in developing nations when a woman is affected by ovarian cancer, or any cancer for that matter. As you can see, it is the third most common cancer among women in India, and about 19,500 of women, they die every year of ovarian cancer. And for the truly underprivileged, when your income, monthly income, family income is less than $100, a cost of chemotherapy and surgery is prohibitively expensive. Just to give you a perspective, chemotherapy only costs, first round, chemotherapy only costs around $250, and a surgery just around $2,500. And this is just a representation of what is the picture in other developing regions of the world. So as you can see, this is where we can have our most impact and help out these women who are in true need of our support. And this is a letter from a patient, Monica. She is a 61-year-old woman, has been diagnosed with ovarian cancer. She's single, she has no support, struggling with life, struggling with finances, and seeking support. And we are working with Tata Medical Center to help her in her journey to overcome cancer. So as Mother Teresa would have said, do not wait for leaders, do it alone, person to person. I had the privilege of volunteering with Mother Teresa during my time in India, and she truly inspired me as a woman. And I know in this room, we all have the power and we all have the strength to make life beautiful, not just for us, but for all the women deserving of our kindness. And I want to take a moment to salute all the survivors in this room. And I truly mean it when I say that you are the strongest women I know. And you are the force and the inspiration behind our organization. So if you want to stay with us on this journey, there are several ways you can help us. If you want to volunteer your time and make an impact globally and locally, please reach out to us. If you have skills in social media, finance, marketing, web development, and would like to share them with us, please email us at info@ovarcome.org. If you would like to donate and contribute to our cause, you can visit our website, www.ovarcome.org, and make your contribution. And any contribution that you make is sincerely appreciated. And finally, we would like all of you to stay involved with us in this journey, stay involved and stay informed via Facebook, Twitter, our monthly newsletters. So all those links are given, and we are going to share this presentation with you so that you have the information and sign up if you would like to. Finally, a round of thank you and applause for our caring champions and sponsors who made this event possible. Air Generate, the founder, is here with us in this room today. Rick, if you could raise your hand. Rice, Jones Graduate School of Business. I graduated from this university from the MBA program in 2004, and Rice has given back to me in several ways, and I'm so indebted to be one of the alums here, and I love you guys, love Rice, and Optimal Strategics for making this event possible. That's all for Ovarcome, and now I'll give it over to Dr. Schneller for her presentation.
Thank you, Rincy, and thank you all for coming. It's really an honor for us to be here with you today. I'm going to talk a little bit about hereditary ovarian cancer syndromes. I'm a gynecologic oncologist at MD Anderson, so I treat women with ovarian cancer. I do both surgery as well as give chemotherapy. And one of the biggest challenges we face with ovarian cancer is the large majority of patients present with advanced stage disease. We're working hard to develop better screening methods, but unfortunately we don't really have ideal screening for the general population right now. One area where we really can make a difference is in women who are at high risk for ovarian cancer, and identifying those women and then screening and performing prophylactic surgery to help prevent ovarian cancer in that group. So there are two main hereditary cancer syndromes, or inherited cancer syndromes associated with ovarian cancer. The first is BRCA, a mutation in the BRCA gene, or also known as BRCA. And the women who have this are at higher risk for both breast as well as ovarian cancer. And the prevalence of a mutation in one of these genes is about 1 in 500 in the general U.S. population. And then the second syndrome I'm going to talk about is something called Lynch syndrome, or HNPCC, hereditary non-polyposis colorectal cancer syndrome. And people who have this inherited mutation are at high risk for colon and rectal cancer, endometrial or uterine cancer, as well as ovarian cancer. And the prevalence for this syndrome is about 1 in 1,000 in the U.S. So people often ask, why discuss hereditary cancer syndromes with women who already have ovarian cancer? And there are a few reasons. One is that we can prevent second cancers in these women. So if someone has breast cancer and we find that they have a BRCA mutation, we can potentially prevent ovarian cancer in that patient. And then also we can prevent cancer in their family members. There are very few of our patients who are both adopted and have no children. So women who have one of these hereditary cancer syndromes can potentially prevent cancer in their family members. And then there are also some treatment implications in women who have ovarian cancer. There's a new class of drugs called PARP inhibitors, so I'll talk a little bit about that are women who have a BRCA mutation have very, very good responses to these new drugs. So as you can see here, 90% of ovarian cancers are sporadic, so there's no inherited mutation that caused them. And in about 10%, the ovarian cancer is thought to be hereditary. Of that 10%, most are caused by a BRCA mutation, with BRCA1 being the most common, and then BRCA2. And then Lynch syndrome, or HNPCC, causes about 2% of those cancers. And then there's some other genes that we've yet to discover that cause the other 5%. The hereditary cancer syndromes are autosomal dominant, and that means that if someone has a mutation, each of their children would have a 50-50% chance of inheriting it. It can be inherited from both the mother or the father side of the family. So many people believe that you can only inherit breast or ovarian cancer from your mother, and that's not true. These genes can also be passed on by men. And a hereditary cancer syndrome is characterized by a young age of cancer diagnosis, multiple cancers in one person, and then multiple cancers in family members. The mutation if someone has a mutation in the BRCA1 or BRCA2 gene, they have a 50 to 85% lifetime risk of breast cancer, and then a 15 to 45% lifetime risk of ovarian cancer, and this includes fallopian tube cancer as well as primary peritoneal cancer. And then other cancers associated with a BRCA mutation are male breast cancer, pancreatic cancer, and prostate cancer. So in the general population, about 1 in 500 people have a BRCA mutation. But in people of Ashkenazi or Eastern European Jewish ancestry, the rate is much higher and is 1 in 40. So if an Ashkenazi Jewish woman has ovarian cancer, she actually has a 40% chance of having a BRCA mutation. Other groups that have a higher prevalence of BRCA mutations are French Canadians, Icelanders, and any other small ancestral groups. You can see here that in the general population, the risk of ovarian cancer is low, less than 2%. But if someone has a BRCA mutation, that risk goes up to about 45%. And if they have a BRCA2 mutation, it's about 20%. So much, much higher than the general population. Some of the red flags that make us think that someone may have a BRCA mutation is if a woman develops breast or ovarian cancer before the age of 50, so premenopausal. The average age for ovarian cancer is about 59, so when we see someone in their 40s with ovarian cancer, that's a red flag to us that they may have a hereditary predisposition. A woman who has both breast as well as ovarian cancer. Bilateral breast cancer, so 2 separate breast cancers. And multiple family members with ovarian cancer or breast cancer. Male breast cancer in the family. And again, anyone of Ashkenazi Jewish ancestry. The cost of genetic testing is about just over $3,000. However, if a mutation is identified in a family member, then we can look exactly for that mutation, and that costs about $475. And then there are certain mutations associated with Ashkenazi Jewish founder mutations, and that's $575. So how we look at it is if we test someone in the family for the first time, it's like trying to find a spelling mistake in a novel. So it's looking for that one page, one line, one word. But once we've identified that mutation in that family, when we test the rest of the family members, we know exactly what page to go to, what line, what word, to see if they have that same mutation or error. So that's why the difference in cost, it goes from over $3,000 down to about $500. Testing is covered by most insurance plans for women who have ovarian or breast cancer. Some Medicare and some others have specific personal and family history criteria that they require to cover the testing. If someone is diagnosed with a BRCA mutation, like for say one of our ovarian cancer patients is diagnosed with a BRCA mutation, we can then test her children and her siblings and often her parents, aunts and uncles. If we discover somebody who has a BRCA mutation, they have not developed cancer, there are a few options. One is surveillance, so screening, where we use a CA-125 blood test and ultrasound every 6 months. We'll do this often in young women who haven't completed their childbearing yet. Another option is chemoprevention, meaning that we start people on oral contraceptive pills. Oral contraceptive pills have been shown to significantly decrease the risk of ovarian cancer by 40 to 50%. So that's one way that we can help prevent it. And then once women are done with childbearing, we recommend that they undergo surgery, risk-reducing or prophylactic surgery, where both their tubes and ovaries are removed. So what we call a bilateral esophageal oophorectomy. This reduces the risk of ovarian cancer by 85 to 90%. There's still a small risk of developing primary peritoneal cancer or cancer of the pelvis. And then the other thing about removing the ovaries in women who are BRCA positive is that it actually reduces the risk of breast cancer by 40 to 70% in women who are premenopausal. So it reduces both the risk of ovarian as well as breast cancer. So once women are done with childbearing, we strongly recommend that they undergo risk-reducing surgery. And then there's a new class of drugs called PARP inhibitors. And as I said, they work especially well in women with BRCA-associated breast and ovarian cancer. They target an enzyme that's involved in DNA damage repair. And they're currently being used in clinical trials. We have one about to open at MD Anderson. But this has really changed the focus of genetic testing from the implications for patients' family members to actually personal benefits and treatment implications. And then the other syndrome associated with ovarian cancer is something called Lynch syndrome. This was first described in 1913. And it's associated with increased risk of colorectal cancer, endometrial cancer, and ovarian cancer before the age of 50. So again, premenopausal women. A red flag for it is if we see a patient who has both colon and endometrial cancer, or colon and ovarian cancer, or endometrial and ovarian cancer. And then people have multiple family members who have colorectal, endometrial, ovarian cancer. And then some other rare cancers associated with this syndrome are stomach cancer, small bowel cancer, cancer of the biliary tract, as well as cancer of the kidney or ureter. So you can see here the lifetime risk of ovarian cancer, as I said, is less than 2%. But if someone has a Lynch syndrome mutation, the risk of ovarian cancer goes up to 12%. Their risk of uterine cancer in the general population, you can see in green, is about 3%. But if they have Lynch syndrome, it goes up to 60%. And then for colon cancer, the risk for women is about 60%, and for men, it's up to 80%. So figuring out that someone has a Lynch syndrome mutation in their family can really have a lot of impact on family members and preventing all these cancers. In people who have Lynch syndrome, the recommendation is for them to undergo colonoscopy every 1 to 2 years. And then for ovarian and endometrial cancer screening, again, to undergo a CA-125 and ultrasound, as well as endometrial biopsy on an annual basis. So again, there's no recommendation for screening in the general population with CA-125 and ultrasound. But these people who are at higher risk because of a hereditary cancer syndrome, we do recommend screening for ovarian cancer. And again, chemoprevention with oral contraceptive pills, and then also with the progestin hormone-secreting intrauterine device, or Mirena IUD, can also help prevent endometrial cancer in these patients. And then again, we recommend risk-reducing surgery once the women have completed their childbearing with both a hysterectomy to prevent endometrial cancer and removal of the tubes and ovaries to prevent ovarian and fallopian tube cancer. So in conclusion, about 10% of ovarian cancers are due to hereditary cancer syndromes. It's really important that everyone know their family history and share it with their doctor so we can identify who's at risk for one of these syndromes. And if we have the knowledge of a genetic mutation, it can help prevent new cancers for the patient and also cancer in their family members. A question we often get asked is who should actually get tested for these syndromes? And it's really important that the genetic testing starts with a person who's affected, meaning the person who has cancer. So if you have a family member who has cancer, the ideal person to test is the person with cancer. Because a negative test in someone without cancer can offer false reassurance and doesn't rule out a hereditary form of cancer in the family. And then, as I said, if a gene mutation is found in an individual with cancer, testing can be more informative and less expensive in the other family members. At MD Anderson, we have a clinical cancer genetics program. In our department, it's run by Dr. Karen Liu, and it's a multidisciplinary program. We have physicians, genetic counselors. It involves our breast cancer department, our gynecologic oncology department, as well as our gastrointestinal department. And we have appointments for new patients to undergo genetic counseling to learn more about these syndromes and then undergo testing if they desire. For women who test positive and don't have cancer, we actually have special screening clinics, high-risk breast and ovarian cancer screening clinics, where we do the ultrasounds and they're read by radiologists who are expert in detecting ovarian cancer, as well as mammograms, breast MRI, ultrasound, to look for early breast cancers. And then we have several ongoing clinical trials and studies that women can participate in. That's it. Thank you.
Thank you, Dr. Schmaler. Our next speaker is Dr. Sood. Anil Sood is professor and vice chair for the translational research in the departments of gynecological oncology and cancer biology, and is co-director of the Center for RNA Interference and Non-Coding RNA at the MD Anderson Cancer Center. He is also director of the multidisciplinary Blanton Davis Ovarian Cancer Research Program. Dr. Sood received his medical degree from the University of North Carolina, Chapel Hill, North Carolina. His research is focused in three main areas: the effect of neuroendocrine stress hormones on ovarian cancer growth and progression, development of new strategies for in vivo siRNA delivery, and the development of novel antivascular therapeutic approaches. Dr. Sood has received major recognition for his research accomplishments, including the Hunter Award, the Margaret Greenfield Carmel Cohen Excellence in Ovarian Cancer Research Prize, and the GCF Claudia Cohen Research Foundation Prize for Outstanding Gynecological Cancer Researcher. Dr. Sood has published numerous peer-reviewed articles and has authored and co-authored several book chapters, and he serves on the editorial board for several journals and as a reviewer for many others. He is an elected member of the American Society for Clinical Investigation. It is my pleasure to introduce to you Dr. Anil Sood.
Well, thank you very much. And I think the introduction was really telling that how many of us cancer touches our lives in so many different ways. My father died of cancer when I was a fellow in gynecologic oncology, and that was one of the main motivations for me, which remains a motivation to this day for doing research and how to improve treatment and outcome of patients with cancer. So, I go back to this slide because this was, again, a very remarkable observation, and it holds true, and I think it will continue to hold true for many years to come. George Engel, was an internist in New York, and he said that, with all the molecular research that we do, that kind of work in itself is very important and it's critical, but biological factors alone don't explain everything about cancer. There are many other things that we need to be attuned to, and that includes the physical health as well as behavioral aspects of our patients in terms of how that can influence cancer. And again, that's part of the reason why we study the kind of things that I'll discuss with you today. And George Engel was actually very influential in even shaping the medical education for students in the long run. Now, when I give this kind of a talk, one of the questions that I always get is that, well, isn't everybody stressed and is everybody going to get cancer? No, not at all. And that's why I started to make a distinction very early in this kind of a talk, such that, acute stress, and I'll define what I mean by that, is actually very adaptive. We wouldn't be alive without it. It helps your brain function better, helps your immune system. There's absolutely nothing wrong with it at all. So what's an example of acute stress? Well, an example is what I'm doing in front of you right now. If you take a person giving a talk in front of a lot of people, that's a stressful event. And the more you do it, the less stressful it becomes. But the point being, there's absolutely nothing wrong with these kind of pulsatile or acute stressors. They're very important for our daily life. But like with most things in life, if you drink a glass of wine a day, it's probably a good thing. But if you drink 20 glasses a day, it's going to catch up with you. Okay? So stress is the same way. If you have chronic stress, that's what we're talking about in the context of being bad for health. Okay? What do I mean by chronic stress? That's a catch-all term that we use, but that entails things like long-term relationship problems, depression, that's, again, major depression that lasts for a long, long time, chronic sleep disruption, loneliness, and a class of individuals that, as a medical system, we pay very little attention to, but it's caretakers of chronically ill people. Okay? Caretakers of chronically ill people are some of the most stressed individuals you'll find, And yet, as a medical system, we pay very little attention to that group. Okay? What's an example? I tell people that, for example, Christopher Reeve, I think many of you remember who he was. He acted as Superman. His wife would be an example of somebody who would be chronically stressed. Okay? Because she took care of him with a spinal cord injury for years and years. She was diagnosed with a lung cancer within 6 months, and she died within 4 months after that. I'm not saying that stress had something to do directly, but that's the class of individuals, again, that we need to also pay attention to. Now, what happens in the context of chronic stress, and how do we understand this? How do we connect the brain to what happens in the context of a patient and cancer and so on? Well, there are two things broadly that we think about in the context of chronic stress. One is that there's something called a sympathetic nervous system that results in production of stress hormones such as norepinephrine, epinephrine. These are the fight or flight hormones that under chronic stress conditions stay elevated continuously. The second is something called the hypothalamic pituitary adrenal axis that results in production of hormones such as cortisol that again stay elevated. And in a normal setting, we see fluctuations of cortisol such that you have peaks in the morning. So early hours of the morning, you have high peaks, and that was just something that came about for a variety of reasons. So if you look at people who have heart attacks, the peak hour for heart attacks is in the early morning hours. That's part of the reasons, because that's when the stress hormones are peaking, and they subside during the course of the day. In chronically stressed individuals, they don't subside, they tend to stay elevated. Now, chronic stress effects for many diseases have been known for a long time, to such a great extent that people who have a heart attack or myocardial infarction, a part of their routine management after a heart attack is stress management. We know that chronic stress can have an effect on heart and many of the systems that I outlined here. So to me, the question was actually almost, why would cancer be an exception? It's just something we haven't understood to as great of a level, but it's, I think, clearly influenced by chronic stress settings. Now, another slide that I find very provocative is something like this. These are all the viruses that are known to play a role in cancer, whether you look at human papillomaviruses, cervical cancer, hepatitis, EBV, on and on. Every single virus known to play a role in cancer is influenced by one or more of the chronic stress pathways. Okay? So the things that we learned in college and medical school, things like, well, if somebody's stressed, that herpes viruses can get reactivated. Well, it turns out that scientifically it's absolutely true. They actually do get activated, they divide faster, and they grow faster. So again, these are part of the reasons why we need to focus on understanding the biology behind these and develop strategies for blocking some of these. So the summary for this first part is that our biobehavioral factors associated with cancer outcome, not for causation. We have very weak evidence for that. But in the context of cancer growth and progression and accelerated growth, yes, we do have clinical as well as laboratory data. Okay? So, and that's why I say that there is consistent association documented for cancer survival and mortality, but for cancer causation, those findings are relatively equivocal. Now, if you look at how cancer spreads, this is a systematic pathway. So for a cancer to get bigger than its very small size, it has to be able to bring in blood vessels on angiogenesis. Then it has to be able to survive the process whereby it invades into other places, and the cancer cells have to either survive in blood vessels, lymph fluid. For ovarian cancer, they have to be able to survive in the peritoneal cavity and ascites, as well as then spread to other places, and that's called metastasis. Why do I show this slide? Because we're taking every step of this process and trying to understand where do stress hormones affect this process and how can we block those. The two things that I put in red is where we have a large body of data now that those are two areas that are indeed affected by stress hormones. So some of the studies we've used are where we've used animal models whereby we grow ovarian cancer cells in the peritoneal cavity of mice. Why? Because ovarian cancer grows in the ovaries as well as in the belly in human patients. So we use models that recapitulate that to try to understand this kind of biology. And if we use these animal models whereby we stress the animals in a chronic stress setting, what you see is that there's an acceleration in tumor growth. So these are aggregate tumor rates at the end of these kind of experiments where you see a 2 to 3-fold increase in tumor growth. And a lot of these pathways that are driven by stress hormones such as epinephrine and norepinephrine can be blocked by blood pressure medications that are commonly used. So if we use a medication such as propranolol, which is a blood pressure medication that's been around for a long time, you can block these kind of increases in tumor growth. So that's a medication that we think is attractive for pharmacological intervention for blocking the effects of chronic stress. So for this part, again, a quick summary is that chronic stress can indeed enhance tumor growth and progression. We now know this from human studies as well as animal model studies, and that a lot of this biology seems to be driven by beta-adrenergic pathways. I didn't mention something called dopamine, but that is a third hormone that actually decreases in the setting of chronic stress. We use dopamine analogs such as Parlodel for a long time. We've used these for treatment of pituitary tumors and so on. Again, replacing that kind of a hormone is an opportunity for blocking some of the effects of chronic stress. And that's what I mentioned as a final bullet, that we're looking toward developing some of these old drugs. These are not new. These are old, inexpensive, cheap drugs as a way of blocking some of the effects of chronic stress on tumor growth. Now, what are some of the clinical correlates? Because of time, I can't show you the body of data that's growing, but I'm just going to show you one study that actually originated from MD Anderson. This was a trial, this was a study, not a clinical trial, but rather a retrospective study that Amal Melham and Breast Oncology led. So this was a study of 1,400 women with breast cancer who, and Amal looked at a variety of drugs that these women were taking. Those with beta blockers had a significant reduction in their mortality or in their progression-free survival, so that they had improvement in progression-free survival when they were taking beta blockers, especially those women who had something called triple-negative breast cancer. And what that means is that those breast cancers lack the certain types of receptors, such as estrogen, progesterone receptors, and as well as the HER2 receptor. Again, this is a very interesting clinical correlate for the kind of work that we've been working on, and similar findings are emerging now for other cancer types, including ovarian cancer as well. So again, the summary of this short talk is that, chronic stress really results in activation of a number of pathways, but predominantly so far we've focused on the sympathetic nervous system as well as the cortisol-related pathways. The net effect is that the activation of these pathways can affect both viruses that are known to play a role in cancer cells directly. They result in immune suppression and promote cancer growth by recruiting blood supply to cancers. And again, part of the reason to do this kind of biology in the long run is to identify opportunities by which we can block these kind of effects on cancer growth. With that, I'll stop, and I want to acknowledge the many people with whom I've had the opportunity to work with. This is indeed a multidisciplinary team because we have psychologists we work with, we have pure cancer biologists, on and on. But really, this kind of a multidisciplinary team is so important when we tackle a topic as complex as this. Thank you very much.
Thank you, Dr. Sood. That was phenomenal. We've had two phenomenal speakers, Dr. Schmaler and Dr. Sood. Dr. Sood is going to need to leave in a few moments. We wanted to give you an opportunity, if you have any questions for either Dr. Schmaler or Dr. Sood, this would be a good time to share your questions. Yes?
Can you buy dopamine?
The dopamine itself, as a substance, would live for a very short time. So that's why we have to use analogs that look like dopamine. So those drugs are available, but again, it's not something that I want to be cautious that it's something we need to systematically study. in clinical settings, and then if it shows promise, then obviously it would get integrated. But we're starting in early trials right now to look at feasibility of treating women with ovarian cancer, especially with beta blockers currently.
So is there anything that you would suggest as far as the supplement is concerned to lower your stress hormones?
Actually, Judith just mentioned that she's going to address some of this in her presentation as well. But you know, a lot of this, in the context of chronic stress management, I think there are two parallel approaches. One is something called by behavioral interventions, what they can handle on their own, and then providing resources for them, such that if those resources are needed. And then the pharmacological approaches, again, we really need to study these systematically to find out who would benefit most from those and what settings should we use these. And so right now the pilot trial that Dr. Lois Remendetta is heading at MD Anderson is something where the beta blockers started prior to surgery, and then it's continued throughout the course of treatment for these women.
Thank you.
What other questions might you have for Dr. Sood or Dr. Schmaler? Okay, with that, well, thank you so much, Dr. Sood. And you're staying, correct, Dr. Schmaler? Okay, so if you have future questions for Dr. Schmaler, she will be here. Our next speaker is Dr. Judith Smith. She is an associate professor in the Department of Gynecologic Oncology and Reproductive Medicine in the Division of Surgery at the University of Texas MD Anderson Cancer Center in Houston, and the adjunct associate professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of Texas Health Science Center at Houston Medical School. She also has faculty appointments at the University of Houston, College of Pharmacy, and the UT Graduate School of Biomedical Sciences. Dr. Smith received a Bachelor of Science in Pharmacy and her Doctor of Pharmacy degree from Union University Albany College of Pharmacy. She completed residency in pharmacy practice and oncology pharmacy practice at the National Institutes of Health, followed by a fellowship in clinical pharmacology at UT-MD Anderson. Upon completion of her fellowship, she joined the faculty at MD Anderson. She has been board certified in oncology pharmacy and certified professional in healthcare quality. Her research focuses on drug development for gynecologic cancers and conditions, with a specific focus on integration of nutritional supplements and herbs with traditional chemotherapy. Please help me welcome Dr. Judith Smith.
I can say good afternoon. We've moved from the morning to the afternoon. So thank you so much for the opportunity to be here today. I wear many hats at MD Anderson, and today I'm going to be focusing a little bit on both what is important on the clinical side, what I discuss with patients often, and some of the areas that we bring back to the lab in integrating both herbal and nutritional supplements in the treatment of ovarian cancer. When I introduce this topic, I'd like to step back and realize why it's important to think about where our chemotherapy agents come from. A lot of times when we think about nutritional supplements and herbal supplements, people feel they're kind of innocuous, that everything is safe because I can buy them over the counter, since they're not regulated by the FDA, that we should assume everything's safe. So I'd like to just remind you a lot of our most cytotoxic chemotherapy agents are also plant-derived. That many of you that have interacted with cancer and chemotherapy at some capacity know that chemotherapy can cause a lot of side effects, and not dosed appropriately or not used correctly could be fatal. So we always have to make sure that we are handling herbal supplements and nutritional supplements with the same eye of caution of making sure that they're safe before we take them. So a lot of the herbal supplements that we see in the clinic can range from different types of tea, like green tea, oral supplements, and other plant-derived compounds. So the naturally derived products are very similar to the chemotherapy that we discussed early, and so we should think of them as medications. Not all of them have been formally studied, but we are gaining more and more information all of the time as new studies are being done prospectively. There's so many different supplements out there, so it's going to take decades before we have information on everything. So we always just have to use a limited eye of caution to make sure we're combining things safely, especially with chemotherapy that we have done formal studies on. We know that they work effectively. We don't want to do anything that may interact with the chemotherapy. So our research lab at MD Anderson has focused on trying to do a lot of the preclinical drug interaction studies and gain that information so that when patients come to clinic, can more confidently say, no, that doesn't interact or that may interact with a little bit more data-based decision. So when we talk about the different supplements, a lot of this gets lumped together in complementary and alternative medicine. And this not only includes the herbal supplements, but also megavitamins that are promoted to take higher doses for well-being and to treat health conditions. Specifically, megavitamin is 10 times the recommended daily allowance. And that's with a eye of caution also, because those daily recommended values are about 4 decades old and haven't been updated, and I don't know if there's any plans to update those daily recommended values. And over the past 4 decades, our society, our food has changed quite significantly. The nutritional value in even some of our fruits and vegetables have decreased based on what's available in the soil is. So with a grain of salt, you might need above some of those daily recommended values anyways. So we have seen a growing increase in the use of supplements, and this is a great opportunity for patients to have some autonomy of trying to help reduce side effects and also prevent cancer or improve their overall nutrition. So overall, about 20 to 60% of the patients are using CAM. We looked at comparing women with cancer versus healthy women through the UT Health collaboration, and found that actually the cancer patients are using much higher incidence than the healthy population right now. But in this population that are using supplements, they're very often combining these with prescription medications. And that's where, from a pharmacology perspective, we get concerned about drug interactions. And the increased use, is definitely for conventional medicine failures when things aren't working, to try and find alternative options. The cost of healthcare is continuing to increase, so looking for alternative sources, and the general interest of just combining therapy to improve outcomes. The main focus why we found patients when we interviewed them, why they're seeking supplements, is to improve overall health, improve immunity, and specifically a lot of the side effects that women experience, like hot flushes, improving libido, depression, weight control, and stress in itself as well. So when I have patients come into the clinic, one of the first things I try to suggest to them is to build a strong nutritional foundation. That will help them undergo and tolerate their surgery better, as well as their chemotherapy. And I often focus on the caregivers as well, because much of what we're telling the patients applies to the caregivers. So as I say, this can be a family or joint effort to try and get everybody on a new nutritional health care path. And so all of us, even in this room today, can have a better nutritional foundation. And there's much controversy around the use of multivitamins. The data can kind of go back and forth depending on what position you want to take. But in general, as I mentioned, overall diets in the U.S. today are not as well fortified as they used to be. So most of us are not getting what we need from our daily diet, even if you're eating all organic and all healthy, good food choices. And those of us that can't always make those healthy food choices, a multivitamin is a good foundation for everyone to have. Women specifically, especially the patient population we deal with undergoing hysterectomy and bilateral oophorectomy, where they're removing their hormone sources, or even postmenopausal women as well, they're at higher risk for osteoporosis, osteopenia, even much earlier in life. So getting on a calcium supplement, specifically one with vitamin D, and even better if you can get one with magnesium, because it helps with the absorption of the calcium to the bone. So this can really help with general bone health, but also with undergoing chemotherapy, your bones and radiation treatments that the patients undergo as part of their treatment of their cancer can really stress the bones, so they really need extra calcium. So I do recommend everyone be on a calcium supplement. We don't have time today to go into the reams of literature coming out on the benefits of omega-3 supplementation. There are benefits from head to toe with the prevention of neurotoxicity, improving immunity, helping with obesity, helping with cardiac function, helping overall skin, and the list goes on and on. So an omega-3 supplement, specifically one from a fish source, is really important because there's some confusion out there with the flaxseed omega-3s versus fish oil omega-3 sources. And it's really important because most of the literature that has shown the benefits of omega-3s are from the fish source. So it's really important. And that's where there's a little bit of research needed on their own part because there's so many different fish oil supplements out there. And you may have one preference over another, which one is easier to tolerate, but definitely part of the core foundation. And the final thing that also help with immunity as well as overall GI health if patients undergoing chemotherapy, as well as just all of us in general health, is a probiotic supplement. And again, there are so many out there. And the general recommendation with probiotics is to get a product that has more than one strain of bacteria so that you're repopulating the gut flora to help with multiple strains. And this will eliminate the unfavorable flora that contributes to insulin resistance, which is associated with cancer pathways, as well as obesity, which overall in itself is one of the major contributors to most cancers now, we're finding out, and overall immunity, because patients undergoing chemotherapy are often looking and seeking ways to improve their immunity, where we get a little bit concerned with mega doses of antioxidants. Using things like omega-3 supplements or probiotics can help build up the immunity without interfering with the chemotherapy. Some other ways to minimize toxicity, because chemotherapy can be challenging. We have looked at the literature and have done some preclinical studies showing that vitamin B6 can help with prevention of neurotoxicity. And the vitamin B family also helps improve energy levels, as well as the B complex of mental focus and cognition. There's a lot of studies that have now shown that long-term memory and prevention of Alzheimer's disease can be associated with continuous supplementation of vitamin B. So this is something that I recommend patients, especially when they're struggling with energy levels and ongoing with chemo fatigue. And ginger tea is an alternative to add to. We have some great antiemetics, but not all of them work 100% to always control all the nausea that patients experience. So ginger tea is a more natural source when patients are seeking some alternative nutritional options for controlling nausea. Some other really good options for decreasing neurotoxicity are amino acids. Specifically, L-glutamine has been shown to help prevent neurotoxicity when used. The big thing that's important with these nutritional supplements is ideally to start them before you start the chemo. So that, again, this is something to get on board as we're planning for chemotherapy or as early as possible. They're not necessarily as helpful in treating neurotoxicity. They're not going to really help treat it, but they can help it prevent it from getting any worse. The amino acid supplementations also help with muscle integrity. We find a lot of patients undergoing chemotherapy can't exercise as we normally would. It can help maintain muscle integrity. Part of the aging process in itself, we have reducing muscle integrity, so the amino acid supplementation really helps in maintaining that and overall muscle strength. We also find that patients don't eat as well during chemotherapy as they normally would. Even if their nausea is well controlled, there's less of an interest. So using things like protein shakes, while it maintains their nutritional value, again, it also can help, the protein source can help reduce nausea compared to a lot of the carbohydrate sources, as well as, again, maintaining muscle. And some of the newer data that's really interesting that we're planning on looking at prospectively is vitamin D, which again has multiple health benefits that we're finding. Increased vitamin D supplementation can help with reducing the risk of cancer itself, as well as cardiovascular risk. But when giving some of our anti-cancer hormones and some of our other chemo agents and helping reducing myalgias and arthralgias, which are a lot of the muscle and joint pains that patients experience that are not well treated with different pain control medications, that additional vitamin D supplementation has been recently reported to retrospectively to help in this condition, and we're going to also try and look at it prospectively. So, what are some of the other commonly used agents when we interview the patients in the breast clinic as well as the gynecologic oncology clinic? We found that there was a wide variety of agents. So we took this list. We actually identified the top 40 agents and have been systematically kind of going through them to look for drug-drug interactions, specifically with the nutritional supplements and different chemotherapy. But you can see that fish oil was one of the top supplements used at that time, as well as continues to be today. And then green tea extract is also very common for its anti-cancer benefits that we've seen in some early phase 1 studies. So when we look at the supplements, what are we concerned about from a pharmacology perspective from the chemotherapy is that it may interfere with how the drug is metabolized, how it's broken down in the body to get eliminated. And sometimes some of these supplements that we've evaluated have prevented the breakdown, which can lead to, you may think, well, that's great, the chemotherapy is sticking around longer, but that also can contribute to increased toxicity. And then what we get more concerned about is when the herbal supplements increase the breakdown or make the drug eliminate faster so that you're getting less chemotherapy. So those are the herbal supplements that we focus in and try to make sure we make clinicians aware of that. There's other studies where we've seen that the herbal supplements can increase drug resistance or the development of drug resistance to the chemotherapy, which would make the chemotherapy less effective. And then the different unpredictable side effects on both your kidney function and your liver function that could either be due to the herbal supplement causing a direct toxicity or from causing drug accumulation. So, and those case reports are kind of sporadic in the literature and not as well known. But that's where you really need to use caution when you're adding or taking away different supplements to make sure that they're safe with the chemotherapy. We get most concerned where, we know that there's data that suggests that the herbal supplements may interact directly with the mechanism of action of the chemotherapy, specifically like agents like cyclophosphamide or ifosfamide, which are alkylating agents, or platinum compounds. We use a lot of carboplatinum and cisplatinum, and even agents like doxil or anthracyclines and topoisomerase 1 and 2 inhibitors can directly have interactions with a lot of our antioxidants as well as some of our other herbal supplements. So that's where we use these so commonly in the gynecologic oncology clinic that when patients bring in that long list of herbal supplements, we try to take some time and systematically go through them and make sure that there's no drug interactions. So, as I kind of say, there's a lot of drug interactions. There are a lot of benefits, too, with some of the herbal supplements that we've stumbled upon in our research. Specifically, one of the mushroom extracts that we've been interested in is a compound called AHEC. And this is a primarily beta-glucan extract of a mushroom from Japan that has shown multiple benefits in immunomodulation, primarily, as well as alleviating the side effects of chemotherapy. We did also notice that it had potential to induce enzymes for detoxification and metabolism. So we first looked at to make sure that it was safe and there was no drug interactions, but then through those studies found that it did have some anti-tumor effects, and looked at this model as well in vitro as well as in vivo in a mouse study. And in the interest of time, I'm going to kind of skip to the mouse study that was most interesting, that we found that with the combination of AHEC, specifically with liposomal doxorubicin, there was an increase, almost a 48% increase in tumor reduction and improvement in overall doxorubicin activity by 30% compared to alone. From the clinical studies from Japan as well as Yale University, we know that HEC is well tolerated, and we didn't find any increased toxicity in the mouse study compared to either agent alone. So we're planning to look at this prospectively as soon as Doxil becomes available. When you come forward and you say this herbal supplement has activity, of course we want to know why. So we did do additional studies to kind of get more specific on the mechanism of action. So we do know that HEC increases the mechanism of apoptosis or cell death compared to docetaxel or compared to Doxil alone, and that its cytotoxicity was independent of Doxil. So this was really exciting because we found a herbal supplement that has no real toxicity of itself, that is acting synergistically with the chemo agent. And the benefit that is that from all the clinical studies from Japan was we know it alleviates a lot of the side effects of chemotherapy at the same time. So it's going to be a win-win of seeing an herbal supplement to alleviate chemotherapy side effects by boosting the immune system, and then also help attack the tumor and hopefully improve outcomes. So hopefully as soon as Doxil or liposomal doxorubicin is more readily available, we can move forward on that study. So, that's basically where we tied in with it, and we'll move on to curcumin, because curcumin is another really popular herbal supplement. It's been in the press as well as very readily available. It has potential targets on multiple pathways that are involved with apoptosis or cell death, as well as the immune modulation. The downside with curcumin is its limited bioavailability. So a lot of those oral supplements out there that you see with curcumin, the downside is that most of it's not being absorbed. And so we don't know how beneficial it would be for the actual activity that we've seen in animal studies. A lot of these animal studies, it's been administered IV or at much higher doses than can be administered to humans. So a new formulation is under development. It's currently in phase 1 studies of the liposomal formulation Dr. Kurzweig developed at MD Anderson, and now SignPath is commercializing. We have worked at it, and we did a lot of the initial pre-IND studies, and looking forward to seeing this hopefully into the oncology clinics after the phase 1's completed this summer. So the promising phase 1 data with oral curcumin, they did achieve stable disease, and it was well tolerated, except that the maximum tolerated dose was below what we saw in the animal studies, and long-term moving forward with the liposomal formulation. And it's currently in open study in Sweden. So, as we move forward on the CAM supplements, generally, when you're looking and considering to take in a new herbal supplement, chemotherapy, or nutritional supplement, take that extra effort to ask your healthcare team, if it's okay with the chemotherapy, and make sure that, there's no potential for drug interactions. And just keep in mind that, even though you may not find anything on the internet, it doesn't necessarily assume safety. We just generally try to caution you from not assuming safety, because a lot of it's underreported and not well known. The FDA just recently started to mandate that supplement companies report adverse effects, effective in 2010. So that database is starting to grow, but it's still known to be somewhat underreported when side effects are occurring. So just do your due diligence in making sure you check out where the products are coming from, make sure that they're being manufactured at high standards, or looking for the acronym GMP standards, or that they have some kind of quality assurance to make sure that the product you're getting is high quality. And just always use your healthcare resources, and there's a lot of resources within MD Anderson, as well as most of the cancer centers that can access the natural database and make sure whatever data is available we can share with you making that decision. Please help me welcome Dr. Monica Robertson.
Thank you, and it's quite an honor to be here today. I'll be speaking about two, I think, very important and very relevant topics, and I'd like to keep my message very simple. As I'm speaking about diet, essentially what I'm talking about is the Mediterranean diet, and please know that these recommendations have been shown to lower the risk of recurrence of cancer in general, and to lower the risk of, or to prevent cancer also. Also, Mediterranean diet has been shown to lower the risk of heart disease, high blood pressure, and diabetes. So I would say in general, there's no going wrong with this. I don't think there's anything wrong with supplements. Supplements can be, at times, appropriate, as we're discussing, omega-3s, for sure. But in general, my main philosophy is let food be thy medicine. So eat healthy, eat a variety of vegetables, a variety of fruits. What's the number one thing you should do to lower risk of cancer with your diet? Eat vegetables. Eat mainly plants. Shoot for at least 3 servings of veggies daily from a variety of colors. Mom had it right. And make certain out of those veggies that you're eating every day, at least one is a cruciferous veggie. You can Google this. What's a cruciferous veggie? Think broccoli, cauliflower, arugula, watercress. Even your coleslaw counts. Have 2 servings of fruit every day. And your goal is a rainbow of colors. Focus on unprocessed grains. Wild rice, brown rice, quinoa, oatmeal, barley. Have some every day. Eat your beans. Minimize red meat. We hear it over and over again. It's the same message for pretty much all disease. Minimize red meat. Focus on cold water fish, wild-caught salmon preferably. Chicken's fine too. Certainly avoid the processed meats, lunch meats, hot dogs, things like this. Avoid sugary drinks. Seasonings are wonderful. Garlic, ginger, onions, turmeric. Another way to get your curcumin that we were just discussing. And drink green tea. I think, very simply, would my great-grandmother recognize it as food? And if the answer is yes, then it's probably okay. My next topic is something very simple that any of us can do any place, any time, and it's not really a thing, it's just a way of being. Wherever you're at, whatever you're doing, just be right here, right now. You want to lower your stress levels? This is how you do it. And there's no right way of being mindful. Again, it's just a way of being. Focus on your breathing. You find yourself getting stressed out, just stop what you're doing, focus on your breathing. There's 2 things that are always with us no matter where we're at. It's always right now, and you always have your breath. So a little exercise that you can take with you today is called 4-7-8 breathing. And I was thinking maybe we could all do it together. So just close your eyes and let your breath out. You're going to take a deep breath in for 4. You'll hold it for 7, and then you'll let it out for 8. Okay? So deep breath in. Hold it. And now out. It's recommended that you do this 4 times in the morning and 4 times at night the first month, and thereafter 8 times in the morning and 8 times at night. And if you forget it, it's on the Facebook page for the Healing Space. Another wonderful way to practice mindfulness is with our eating. So much of the time, don't you find that you're rushing through your meal, watching TV, not really noticing what you're eating? So you can apply it to dinner tonight. When you sit down to eat, turn off the television, look at your food. What does it look like? How does it smell? And then slowly eat. Chew each bite. And if all of this has really hit you in a good way, you could try spending 5 minutes tonight before you go to bed. And this too is on the Facebook page and also on my website. I have a little blog on the website. It's www.thehealingspacehouston.com. You sit in a quiet place, and I like to repeat 4 words. They're love, compassion, harmony, and healing. But there's no magic to those words. Those are the words I like. Repeat any words that are right for you, and just say the words to yourself over and over again. There's no special way to meditate, but this is one way that I like, and it's very simple. And I'd recommend it to everybody.
Thank you very much. I particularly like mindfulness. Many years ago, I had to learn how to eat a raisin. It'd take like a long time to eat one raisin and feel the texture and enjoy it and experience a raisin and being endowed with raisins. Thank you very much. Our last speaker is Dr. Dave Balachandran. He is an associate professor in the Department of Pulmonary Medicine and director of the University of Texas MD Anderson Cancer Sleep Center. Dr. Balachandran completed a fellowship in pulmonary and critical care medicine at the University of Chicago Hospitals and Clinics and a sleep medicine fellowship at Beth Israel Deaconess Medical Center in Boston, Massachusetts. He has extensive clinical experience in the care of cancer patients with sleep disorders. He is an investigator on multiple research studies focusing on cancer-related fatigue, evaluating the interrelationship between cancer-related fatigue and sleep disorders in cancer patients, and improving cancer-related fatigue in patients with hyperthyroidism in the elderly. Dr. Balachandran's most recent collaboration involves measuring sleep-related complaints in patients undergoing total brain irradiation for neurological malignancies and understanding the association of alterations in sleep with severity of fatigue. Please help me welcome Dr. Balachandran.
It's always difficult to get up and have to talk about sleep right after lunch. Do a good job. I want to thank Runcie and everyone at Ovarcome for inviting me to speak to you today. It's a wonderful opportunity to be with you. I want to talk about a topic that I've been interested in now for several years, initially in sleep and now in sleep and cancer. I think it's an area that's not well developed, and we're starting to do some investigation in the Anderson. We're starting to gain some traction with some other centers across the country. It's a problem that's fairly significant. This very busy slide just shows a list of different sleep disorders and different cancers and the overall prevalence just in one study. And you can see it ranges anywhere between 18% all the way to 50% in certain cancers. And in your gynecologic cancers, you can see that over almost 50% of patients feel some development of fatigue or insomnia, restlessness during sleep, excessive daytime sleepiness or EDS on that slide, or have abnormal lid movement. So it's a very common problem. What we notice that in all cancers, these symptoms of different sleep disorders, they increase after treatment. So people come to their cancer with a certain amount of symptoms, and once they're treated for their cancers, the symptoms unfortunately tend to progress and they become more symptomatic. So it's really an opportunity for us to try to identify these problems early and intervene to see if we can make a difference. When we talk about cancer care, we tend to talk about a spectrum of cancer care. When we talk about preventing cancer, treating cancer, and going on into survivorship. And sleep really impacts all 3 aspects of this care of the clinical care of cancer. In terms of preventing sleep, there's data that I'll share some with you that inadequate sleep, disturbed sleep, abnormal circadian rhythms can actually lead to things such as cancer and other diseases. In terms of intervention, we realize that patients come to us with their sleep disorders that need to be treated. We understand that during the course of therapy, whether it's radiation, chemotherapy, surgery, they have more sleep disorders, and there are toxicities from chemotherapy that continue to affect sleep well into survivorship, where patients complain about fatigue, insomnia, chemo brain, lack of cognition, and even things such as sleep apnea that we'll discuss later on. This is one study that showed the rotating shift work in a very large population of nurses, almost 80,000 subjects who were nurses, who worked rotating shifts, so had abnormal sleep patterns throughout their lifespan. And what they found is that if you had more than 30 years of increasing rotating shifts and abnormal sleep, you had about a 40% more likelihood of having breast cancer. So it was important to get those normal sleep patterns. Another study is another study with over 100,000 patients from Japan, actually subjects from Japan, they don't have cancer. And I'm bringing this slide out to you to show you that how you sleep matters in terms of what illnesses that you may be predisposed for. And what you can see in that green box there is that patients who slept less than 6 hours or slept more than 9 hours had an increased incidence of cancer. For those who slept less than 5 hours, you can see it was 1.7 increased risk of cancer. And for those who slept more than 9 or 10 hours, for more than 10 hours, went up to 2 folds. And this study's been repeated multiple times in now almost 1 million patients, and these data have stayed very consistent. One of the reasons for this might be the impact of melatonin on cancer. Melatonin is a very important hormone that doesn't get a lot of press, but it's very important for sleep and actually has some oncostatic or cancer treating or preventing properties. There's studies that show that patients with melatonin, if you take a mouse, like Dr. Seuss showed, and you withdraw melatonin from it, the tumor growth actually increases. Melatonin is really tied into sleep and the light-wake cycles. The circadian rhythm is the term we use for that. When we are in bright light, melatonin production shuts off. When we are ready to go to sleep, melatonin production increases. And as we turn off those lights, and it's really important to turn off those lights when you're going to go to sleep, melatonin production increases to the point that it allows us to fall asleep more easily. And if we're exposed to bright light, and that means computers, televisions, or just the lights in the room, that actually can really quickly destroy melatonin. And recently we've learned that the blue-green light spectrum is really important for shutting off that melatonin secretion. And that just happens to be the exact spectrum that is preferentially promoted by our LED screens on computers and tablets and cell phones and that such. So it's very important to get those things off in the bedroom. Sleep deprivation has been shown now in many studies, and I just brought a couple samples to affect our immune systems. How our immune cells function actually has a nice circadian rhythm. So when we do things that interrupt that circadian rhythm, go to sleep at the wrong time, wake up too much during the night, we can influence how our immune system works. And immune surveillance, as you all know, is very important for cancer prevention. If those cells don't work right, they can't correct the mistakes that cells make and clear those cells out of the bodies effectively. So we think that sleep deprivation and abnormal circadian rhythms affect the immune system and can promote cancer. And this very nice study from Nature kind of looked at that whole spectrum of illness, looking at circadian rhythms, looking at sleep, looking at the immune system, and this very complex reciprocal relationships between these different areas, and looked to see how that affected immunity. And they postulated that this might have ramifications for treating infections, developing infections, as well as malignancy. One important symptom that is sleep-related in patients with cancer, and a very prevalent symptom, almost 80% of patients with cancer experience cancer-related fatigue either pre-treatment, during treatment, or into survivorship, and that is cancer-related fatigue. And this very complex definition is just a distressing, persistent sense of tiredness or exhaustion that is related to cancer treatment. And the last part's very important. It's not proportional to your activity. It's not because you ran a marathon that you're fatigued. You're fatigued without running the marathon. And it interferes with your usual functioning. People just cannot carry out the activities they enjoy and the activities of daily living that they need to do because of this overwhelming sense of fatigue. It's multidimensional. There are emotional, physical, and mental aspects. And it can, as I mentioned, can occur anywhere in that spectrum of cancer care, from prevention all the way to survivorship. And what's really interesting, that 30% of patients complain of fatigue even up to 10 years after their last cancer treatment, so it's very persistent. There's many different causes of it, including poor nutrition, which was addressed here today, cancer treatments, other symptoms such as pain, mental illness, comorbid conditions such as heart disease or diabetes, and of course the medications we use to treat cancer, such as cancer-related pain, such as opioid narcotics. Cancer treatments are, all the cancer treatments that we have can cause fatigue and sleep disturbance. And sleep disturbance itself, we divide them into different aspects. They're usually multifactorial. Patients may have different levels of all of these things. There can be behavioral components, which can lead to insomnia. There can be circadian rhythm disruption, as I mentioned. We've learned now that patients with end-stage cancer have very disturbed circadian rhythms, and that affects their sleep. And patients going through chemotherapy have abnormalities in their circadian rhythms, which can also affect their ability to both stay awake during the day, which is daytime sleepiness or fatigue, as well as insomnia, causing them not to get that good signal to go to sleep. Medications we use, both narcotics and other drugs we use in cancer care, can affect sleep. Primary sleep disorders, such as sleep disordered breathing, more commonly known as sleep apnea, can also affect sleep. And leg movement disorders, we mentioned some of the Taxol type drugs, and they can cause neuropathy, and that can cause leg movements during sleep that can be very interrupted. And of course, all the sleep disruption contributes to things such as chemobrain, that lack of good cognitive power and memory loss that so many patients with cancer experience. Let's go over, I think, the most common cancer-related sleep disorder, which is insomnia. The prevalence is thought to range anywhere from 20 to about 63%. It's often associated with a psychiatric overlay, such as depression or anxiety, and is really characterized by very intrusive thoughts, difficulty falling asleep because you just have this, can't shut your brain off, it keeps going at night. We feel that there is a role for abnormal circadian rhythms, and the good news is there are effective therapies that have been shown to work in the cancer setting. CBT stands for Cognitive and Behavioral Therapy. We're going to discuss that in a little bit. And of course, there's pharmacological therapies for sleep, sleeping pills in other words. One of the most important areas of cognitive behavioral therapy, the behavioral part of it, is working on sleep hygiene. That's a very fancy term that just means these are the habits you need to promote good quality sleep. One of the most important ones, again, this gets to that training of normal circadian rhythm, is going to sleep at the same time every day and waking up at the same time every morning. And that way, you get your brain on a cycle and a system. Your brain likes that regularity, and it helps you establish a nice circadian rhythm to promote both sleepiness during the night as well as wakefulness during the day. Using the bedroom only for sleep. Get the television out of there. Get those other activities out of the bedroom. Do them somewhere else, and when you're tired enough to fall asleep, go into your bedroom and sleep. Only going to bed when you're sleeping. Don't stay in bed for too long if you're not sleeping. That's really important. What you're trying to do is build an association between your bed and bedroom environment and sleep. And if you do other activities in there, have those intrusive thoughts in there, those frustrating thoughts, staring at the clock, looking at the ceiling, worrying about how I'm going to get through the day tomorrow because I didn't sleep well. You want to take those activities outside the bedroom and only concentrate on your sleep when you're in the bedroom. And then avoiding things like caffeine. The half-life of caffeine, if you all had 2 cups of coffee in the morning, that's about 400 milligrams of caffeine. The half-life is 12 hours. So that means if you had it at 6 p.m., you still have half of that caffeine still in your system. And so you can do the math that at 12 midnight, you still have a quarter, about 100 milligrams of caffeine in your system. So even that 2 cups of coffee in the morning can still affect your sleep at night. So as best as you can, eliminating the caffeine, avoiding exercise 2 hours before your bedtime is also important because that's very stimulating. So these very basic rules can go a long way into treating a lot of sleep disorders that our patients have. There's some fancier techniques that we can go into. Sleep restriction therapy is used. It's to prevent you from spending too much time in bed, very simply. Stimulus control. Again, not staying in bed when you're not sleeping, going into that other room, doing something relaxing, getting back to the bedroom only when you're ready to fall asleep. That's another way of promoting good sleep. There's relaxation techniques. I think we just heard about one of them, such as meditation that can help. Keeping a sleep diary, being aware of your sleep habits and monitoring it, make sure you don't get off your timings and off your schedule. Just writing those things down can actually be very helpful. And cognitive therapy, this is best done with someone who's trained to do this. Understanding your thoughts towards your sleep into your life and how you can substitute positive thoughts for negative thoughts in terms of how you want to sleep. That's very important. So CBT, or cognitive behavioral therapy, is probably the most fundamental thing you can do to promote good sleep. If effects are persistent and there's no toxicity, so it's a wonderful treatment for sleep disorders. Another treatment that's used quite a bit are medications, of course, and we're all familiar with those. They fall into different classes. There's benzodiazepines, those are like the Valium-type drugs, or Restoril or Temazepam. And then the ones that you're bombarded with on television, usually at nighttime, the non-benzodiazepine sedating drugs, such as Ambien, Lunesta, Sonata, they do have a role. We won't talk about much more about these medications. They are used. They're used best usually in temporary settings or short-term periods, and they all have side effects. They're all addictive, except perhaps with the melatonin agonist. In elderly patients, they can lead to things like falls and urinary retention. They all come with a price, so you have to think very carefully how you're going to use them in a particular patient. That's why I really advocate the CBT, because I think that's a much healthier approach to your sleep. There are diseases that are more prevalent in patients with cancer, especially patients with lung cancer, head and neck cancer. They tend to have more sleep-disordered breathing, or sleep apnea. That's an important diagnosis in itself. Recently, actually, we just learned in a paper that was just published last month that patients with untreated sleep apnea have a 5-fold increased risk of cancer-related mortality or cancer-related death. So it's actually thought to actually directly cause cancer now. And sleep apnea is where there's closure of the upper airway during the night when you sleep, so that you don't breathe. The oxygen level in your blood falls, the carbon dioxide level in your blood rises, and that causes a stimulus to the brain that actually wakes you up at night so you take a breath. And most patients will fall right back to sleep and do the same thing. So it's a cycle, closing the airway, opening of the airway associated with these arousals of sleep. And what that leads to is very fragmented sleep throughout the night. You're sleeping in little bits and pieces all throughout the night. It leaves you feeling exhausted in the morning and tired in the morning and feel like you haven't rested. So it's an important diagnosis, and we've seen a lot of patients that we've been able to help by treating their sleep apnea. Restless leg syndrome is another sleep disorder that's fairly common in cancer patients. In patients with anemia, which is a lot of cancer patients, it's more common. In patients who've had certain medications, any of the medications end with platinum, any of the metal-based drugs, and all the drugs that are taxane-based can cause neuropathy, basically nerve damage, and that can lead to these abnormal sensations in your legs that typically occur right at bedtime. They get better with movement, and it keeps people up throughout the night. And it also disrupts their sleep in the same way that sleep apnea does, by causing that sleep fragmentation. So what we do at MD Anderson, we're fortunate to have a sleep center within MD Anderson in our facility, and we offer consultation for sleep disorders. And we can test patients with polysomnography, or you might have heard it called a sleep study. And we can evaluate things like sleep apnea, restless leg syndrome, and other sleep disorders that may affect patients who have cancer. And we can try to help people understand that. And we do, as was mentioned, have some research studies to help to develop techniques and see what works in cancer patients. So just to conclude, very simply, sleep is essential for life. We all knew that before you came in. But I want to reiterate because it's very important. You know, every creature on Earth sleeps for different varying parts. So it's very essential. It's well preserved through evolution. That it's something that, despite it makes us weak, I mean, we're vulnerable when we sleep. But despite that, we all sleep. So it must be very important. And every day we learn more about why it's important for memory, for life. And if you don't sleep for more than a week, people do die. Cancer and cancer therapies can disrupt sleep. That's well recognized as well. And the good thing is that what we're trying to do is understand how those therapies disrupt sleep and try to find ways to prevent and also treat those. And I think there are solutions out there. Thank you.